It's really wonderful to see you all. My name is Peter McBride. I'm the director of the Cohen Center. You can hear from my accent that I don't come from these parts. I come from Northern Ireland, and I moved to the States just at the end of the summer. So it has been a really interesting time to come here. There are a couple of things I want to say at the start. We've got a really interesting evening ahead for you. There are a couple of things I want to acknowledge. The first is that certainly from where I'm sitting on land that was originally owned by Native people, and each of you will also be sitting on land that was owned and is owned by our Native peoples. And I just want to acknowledge our place in relation to that. And I suppose the second thing I want to acknowledge is what happened yesterday and has gone on today. I'm sure it's in the front of all of your minds. I think there's a heaviness around and an anxiety about what is going on, and I think it's really important to acknowledge that. Tonight, what we're talking about in the context of faith. So we thought that perhaps we would start the event this evening just with maybe 30 seconds or 45 seconds of silence, where each of you, in whatever faith tradition you are in, or if you are in none, just have the opportunity to reflect on, to pray, to think about what has happened, to take a deep breath, and to just to reflect on what is going on. And then I've asked at the end of that Reverend Wells and Rabbi Davidson would just conclude that time of reflection with a few words of prayer. So let's just take 45 seconds or a minute to reflect on what's been going on.
Lord, make us instruments of your peace. Where there is hatred, let us sow love. Where there is injury, pardon. Where there is discord, union. Where there is doubt, faith. Where there is despair, hope. Where there is darkness, light. And where there is sadness, joy. Grant that we may not so much seek to be consoled as to console, to be understood as to understand, to be loved as to love. For it is in giving that we receive, it is in pardoning that we are pardoned, and it is in dying that we are born to eternal life. Amen.
God of history, tonight as we pray for our nation, we ask that you send us men and women of inspiration and insight, visionaries to build nations and communities in your image, stewards dedicated to justice, unafraid to face the challenges of our day, in particular the challenges of pandemic and prejudice, so that our cities and country resonate with compassion and health, justice and mercy, kindness and peace. Bless our leaders with dedication and foresight, fortitude and imagination to solve the complex issues that threaten our future. May they lead us to a time when neighbors embrace and communities thrive, a time when liberty and equality reign supreme. Source and shelter, grant safety and security to all nations and communities, so that truth and harmony will resound from the four corners of the earth. Let the light of wisdom shine brightly in the halls of power, a beacon of hope for every land and every people. And together let us say, Amen.
Amen. Thank you very much, Jason and Beth. There's something incredibly powerful about 50 or 60 people, even when it's on Zoom, just taking a moment of silence and reflecting. So I appreciate the sincerity of your participation in that. The silence of our time together was really powerful. We have a wonderful time together this evening. It's going to last about an hour and a half. I would ask you, just in terms of protocols, we're going to try and manage this as carefully as possible, but I see most of you have got your mics on mute. That's great while we've got our speaker speaking, and then obviously when it comes to participation, don't forget to unmute yourself. I see people have got the phrase that's going around for 2020 or 2020, people with t-shirts is, I didn't realize I was muted, because we've become so used to it. So there will be three parts to tonight. The first part is a presentation or a discussion from our three guests: Bobby Bagley, who's the Director of Public Health and Community Services for NASHA, Kirsten Durzy, who's the Equity Council Lead, and Dr. Dottie Morris, who's the Associate Vice President for Diversity and Inclusion in Keene State College. And those three people were involved with the Governor's COVID-19 Equity Response Team, who were a team of people who put together a report to look at the issue of racism and how there was inequity in how people experienced COVID. And the reason that we've chosen this is it's one of the ways that we can begin to think in a tangible way about systemic racism and the way that our society and the systems within our society can have inherent prejudices associated with them. So Bobby, Kirsten and Dottie will speak to us for around about half an hour. And then at the end of that, we will split you into groups just to give you the chance of a more intimate connection with other people within this meeting. And those groups will be of 5 or 6 people. They won't be facilitated. What we've got are 3 questions that we're going to ask you to think about. I'll talk about those whenever our speakers finish. You'll have half an hour in those groups, and then we'll come back together as one big group. And this is when it becomes really interesting about how we manage so many people together. But we'll come together as one big group, and there'll be the opportunity for us to talk all together as a group. And I promise you, we started at 6. We will be finishing at 7:30. So for those of you who are making plans, we will not go longer than that, I promise. So without further ado, I'm going to hand over to Kirsten. I think is going to lead off with Bobby and Dottie to speak to us this evening.
Well, good evening again. I am Kirsten Durzy, and I was a member along with Dottie and Bobby of this year's Governor COVID-19 Equity Response Team. And we did some significant work in building a report examining the impact of institutional and systemic racism and other long historical discriminations in our society on public health, and particularly on the response and the impact of a pandemic like COVID-19. So in that report, we did a lot of background information and then a set of really significant recommendations. So we thank you for the invitation to come and speak with this group tonight and share some of that information with you. So I'll move through. This is probably a slide that I don't even really need at this point, but honestly, the question is why now? Why talk about equity now? And, I think that these are all some headlines that we saw very early on in the pandemic process that really indicated that the world was sort of coming to grips with the realization that there were significant health disparities already present in our world, and that those health disparities were going to be amplified by something like a pandemic. That was not news to many of us, but it seemed to be news. If you looked in the sort of public discourse, it did seem to be news for a lot of people, a new sort of conversation and a new experience talking about the impact of, particularly the impact of racism on health. And so why now? Okay, so it really became a very relevant conversation in the public discourse. It was happening, of course, at the same time as the murders of George Floyd, the Black Lives Matter movement being very present and vocal, and I think a lot of our society really coming to grips with the need to talk about and understand racism and our role in it. So, as I said, when we have something like a pandemic happen in the world of public health, just like any other crisis, health or otherwise, it really is just an opportunity to sort of unmask some of these long-standing inequities that have occurred. And that the COVID-19 pandemic was no different. I always liken it to like a tsunami, right? It comes rolling in very slowly, but it pulls with it. It doesn't stop. It just pulls with it every existing systemic and structural inequity that was present, and it pulls it even further and amplifies it so that it wrought devastation along the way. And that certainly is what we've seen with COVID-19. The governor in late May pulled together a team in response to some calls to really address here in New Hampshire issues of racism and its impact on public health, and particularly how we would have an equitable response to the COVID-19 pandemic. He pulled together a small team. This is our team. It was Bobby Bagley from the City of Nashua Division of Public Health, myself from the State Public Health Department, Rogers Johnson, who was the president of the Seacoast NAACP and may have been somebody that many of you, if not all of you, knew very well. And unfortunately, tragically, we lost Rogers recently. Dottie Morris, who is at Keene State College, and Trinidad Tejas, who was the previous director of the Office of Health Equity at the state of New Hampshire. We initially were charged in late May. We had about 30 days to work. We worked furiously late nights and early mornings and weekends for about 34 days. We stretched a few extra. And we submitted our report back to the governor's office in July, and he released it publicly in late July. And since then, we've been doing a lot of work trying to move some of the recommendations forward, and also consistently in conversation with groups like this group who want, and some of them in sectors and areas we've never talked to in public health. It's been a really interesting conversation. And in the meantime, we have been working directly in the COVID response as well, and sort of putting some of our own recommendations into practice. The link to our report is here. It is on our COVID-19 DHHS page, where all of our COVID-19 information lies, but as that page gets fuller and fuller every day, it can be difficult to find. So the link is here if you'd like to read the full report. So what is this concept of health equity? Well, it really just means at its purest sense that everyone has a fair and a just opportunity to be as healthy as possible. And what does that mean? Well, it means that people have what they need when they need it. And what I need may be different than what you need, and when I need it may be different than when you need it. And the form in which I need it may be different than the form in which you need it. So this really is about meeting people where they are at and providing what they need when they need it. Equity in that sense, different than the concept of equality. Right? Equity is really about attending to what people's individual needs are, or societal needs, or community needs. And it's not always about the same thing for everyone at the same time. So just to sort of drive home whether we do or do not have equity, or whether we are or are not seeing significant health disparities in our state related to COVID-19, I wanted to share some up-to-date information with you. So We track currently, cases, new cases, infections. We track hospitalization, and of course, we track the most tragic outcome of COVID-19, which is death or mortality. And for all of that, we attempt to gather as much information about a person's race and ethnicity as possible, because we know that there are significant drivers of health outcomes that are tied to race and ethnicity, and significantly tied to racism in particular. And so it's important for us to have that data so we can really look at whether we are seeing disproportionate impacts for racial and ethnic minorities in our state related to COVID-19. I think it can be a very easy conversation to have, to say New Hampshire's different, New Hampshire's unique, New Hampshire's, fill in the blank. New Hampshire is, yes, we are different. We are a very special state, but we are not unique. We are seeing the same significant health disparities in our state that are being seen in other states, and in many cases, they're worse here. So this is some information. This is from the COVID Tracking Project, which has done a significant amount of work around disparity data related to COVID. So you can see that when you look at cases and death, that the rates are much significantly higher amongst Hispanic and Latino populations, and Black and African American, and then moving on down as well. And in our state, we see that as of January 6th, racial and ethnic minorities were 2.5 times more likely to have a COVID-19 infection, and almost 4.5 times the rate of hospitalization, and 1.5 times the rate of mortality or death compared to our white New Hampshire residents. And that's after adjusting for differences in age distribution, which is a very significant driver of poor health outcomes for COVID-19 in particular. So, so you can see that we have very significant health disparities and disproportionate impact of COVID-19 in our state. It is not different than really any other public health crisis, infectious disease, or chronic illness. We also see these disparities across almost every other illness as well. So I think the question then comes to why. And so this is a framework that we refer back to a lot in the report, and we share often. This is actually came from the Vermont State Health Improvement Plan, and they took it and adapted it from the Bay Area Regional Health Inequities Initiative. And this is really the upstream, downstream image of what drives health and what drives health outcomes. So if we start on the right side of this image, you can see the issues that we talk about a lot and that you hear about a lot. If you're in our world in public health or healthcare, you talk about this a lot. If you're maybe not, you may be seeing it in the public discourse, you may be experiencing it with your own family or friends or yourself, or you may just be reading about it or hearing about it elsewhere. These are the issues we talk about a lot, right? Like, what are the behaviors that drive health? What are the diseases and injuries that occur related to those health behaviors? And ultimately, what's the poorest health outcome, which is a reduction in life expectancy, or a poor quality of life, or actual death, ultimately. And those are all really important issues. We live in that world, and we live in that world for a very significant reason, which is that this is where people suffer. And I'm certain that you either yourself or someone very close to you has suffered significantly from COVID-19. I don't know that there's anybody left in our world who doesn't have a personal connection to somebody who has had the ultimate poor outcome related to COVID-19. So we spend a lot of time here because we don't want people to suffer. And so this is where a lot of our public health work and resources go. And by resources, I mean money. This is where our human capital and our money goes. This is where a lot of those public health programs that you read about or hear about, or you maybe give money to, live. And they're really important programs. But these are not the ultimate drivers. So what happens is, if we move a little bit further to the left, we begin to look at issues like living conditions, the places where we live, work, play. These are our social determinants of health. You may have heard that terminology. And so these are the places like, do people have access to safe and secure housing? Is there a green space for them to be in? Is the air quality good? Are they able to access the justice system appropriately, or has the justice system not been fair to them? Are they experiencing or witnessing violence? Are they employed? Do they have a reasonable income? These are all real. These drive all of those adoptions of risk or health behaviors, and the choices that people make are often tied to the living conditions, the social determinants in which they're experiencing. So if we really want to affect some of that downstream risk behavior or that disease and injury, we need to have an impact on the social determinants. So as we get a little more progressive in our public health or our healthcare, our social service, our community health work, we start to move some of our resources a little further upstream and put them into programs about green space and housing and clean air and education and employment. And that's also really critical, but it's also not this most significant driver. So if we still continue to move further to the left, further upstream, we start to talk about the real drivers, the historical, institutional, systemic inequities that exist and have existed for many, many, many generations in our country. And those are things like inequality of wealth distribution, ableism, gender discrimination, class discrimination, and most significantly, racism. And so if we really want to address the downstream issues like disease, injury, and mortality, and the suffering of people, we have to move our work and our resources upstream more than we have. We are learning those lessons, and I think there has been a lot of movement, a lot of recognition, and COVID has driven that home maybe more than anything I've ever witnessed in the world of health and public health. But this is really where we need to be. So I think, when I think about some of when we talk about the historical impact, I was thinking a lot about this yesterday, and I appreciate the call to reflect earlier in this meeting about what we've all witnessed and experienced. And I think about the very clear engagement with the police that was different than the engagement with the police that occurred when there were protesters protesting the death of George Floyd, or there were protesters holding up the movement of the Black Lives Matter movement, and how that was so significantly tied to how our systems were built and who our systems were built to support and hold up, and who they were built to hold down. And this is all in there. This is all in the upstream driver of health. And so, our system was built to discriminate. It's not, I say this a lot, it was not a bug, it was a feature of the way that our systems were built. And as that has happened over time, we've seen that move people into much more precarious living conditions, not at their fault. This is the way the system was built. And as they're in precarious living situations, if they're experiencing precarious social determinants of health, they are then, that is impacting the behaviors that they're able to select from. And that, in fact, is impacting their disease, injury, and their mortality. And that has played out with COVID as well. So when we made our set of recommendations, it was really, really important that we spent a significant amount of time in the report talking about what is the background, what is the context in which racism and other social inequities, systemic inequities exist. How were they built? How did they grow over time? And what impact do they have on an individual and a community's health? And if we felt really strongly that if we didn't make that case, we couldn't really lay out good recommendations, or people may read the recommendations, but they may not understand why would they make a recommendation like this, as opposed to something else. So we tried to strike a balance in our recommendations of addressing downstream issues and also addressing upstream issues as well. So we only have a limited time. Otherwise, I would go through each of these 64 recommendations with you, but I won't be able to do that tonight. But what I can tell you is we grouped them under 11 strategic pillars. And the first pillar really was COVID-19 specific recommendations. So those are things like equitable allocation of vaccine planning, or ensuring that testing is available to all populations at no cost, with no barriers, mandating mask use and ensuring people have the ability to isolate and socially distance if they have to. And then we went on to talk about some other issues that were not necessarily COVID-19 specific, but they were tied to health inequities. And so we took our charge to talk about COVID-19, and we sort of broadened it and said, yeah, well, we can talk about COVID-19 and we must, but we also must talk about just health inequities and equity in general. So we talked about the need to look at something like an equity response team that was put into place related to COVID-19 and in response to COVID-19, but the state needs one, we believe. The state needs one permanently enacted and codified and available to not just respond reactively, but to think proactively, to think about what our state needs. This report was not written, it was written at the request of the governor, but it was not written for the governor or the government. It was written for all sectors and people across New Hampshire. However, we recognize that a lot of our sort of resources and legislation and policy is enacted at the government level. And so we felt like it was critical to talk specifically about how we can align our government systems for equity to really weave that thread of equity through all of the work that our government systems are doing, whether it's in business relations or transportation or public health or education, that we're really thinking creatively about how does equity flow throughout that. It's not a separate issue, it should flow throughout. We talked specifically about the need for organizations, whether they're faith-based or other organizations, to address their own cultural effectiveness. And some of that is outlined, well, it's all outlined in the report. We have 7 very specific recommendations about becoming a culturally effective organization, everything from increasing data collection to staffing, to diversifying your staff, particularly your leadership, and to sort of everything in between. We talked a lot about equitable data practices. I am an epidemiologist, trained as an epidemiologist, and data is the language that we speak in public health and in health, but it is as fraught with issues of inequity and racism as every other area. And there are ways to think about data practices that are equitable. How do we capture stories and understanding of people that are more equitable? So we outlay some very specific recommendations there. We call for an increased knowledge and understanding about our communities at risk for experiencing disparities in New Hampshire, and particularly our communities of color. You know, it's and that we really think about doing that in a very equitable sort of research-based way with a cross-sector team of community members and other types of experts who are at the table really thinking about what do we need to know, what do we want to understand, and not just from a deficit-based perspective, which is often the case, but from an asset-based perspective as well. We call for system accountability for equity, for systems to do the type of work you're doing today, which is to talk openly and often about the impact of race and racism on the equity that's present within an organization, and also the equity that as the organization is sort of helping shape in the world. How do you become a more just system? And so we talk about some practices that are recommendations for that. We make some specific recommendations for equity promoting strategies, and most significantly, we call for a really resource-heavy investment in the use of community health workers across our state. This is a tremendously effective and culturally relevant and culturally effective way of doing the work that we need to do. And then we talk about a couple things that often are not talked about in the world of equity, and one of them is equitable resource allocation. So we move a lot of our money, whether it's government money, federal money, you know, through our state and then outwards. We also move money and resources through donations, individual donations, charity work, and foundations. And all of that is good, and all of it is often inequitable. And so there's a lot of work, particularly amongst some of our larger foundations and our government funders, that can be done to ensure that resources are really allocated equitably, particularly to marginalized communities. And then lastly, we make some call for an increased community engagement. We had a very limited period of time. We are, the five of us, incredibly engaged with our own communities, but five of us was not a wide enough, a big enough number of people to have a good discourse. It was not diverse enough. It was just not enough. And so we need more community engagement. And lastly, you know, we call for significant work in the realm of legislative and other policy as well. So I don't know if I needed to keep this slide, but I just wanted to share with you that if you go to our newhampshire.gov/COVID-19 website, which again is very, very full of information at this point, but near the top, you can find something called the Interactive Analytics Dashboard. And this is where you can monitor the disparity, particularly disparity that may or may not be present. It is currently, but present in our COVID-19 cases and hospitalization rates, and of course mortality as well. For your information, there are other tabs in that dashboard that will bring you information about sort of where the infection is moving across our state, where it is present. There's information about school systems, where there are cases in school systems, and we will be adding information about vaccine distribution as well. So that's my quick share of our report, and I'm going to turn it over to Dottie now to to take us into the next section.
I just have a couple things to add to what was already said. And one is some of the historical pieces around how the team became a part of this whole process. And two, the methods that we used, even though we wish we could have had more community input, we had a lot of community input, the way that we reached out to people. So the first part is Rogers Johnson was the chair of the governor's committee or council on diversity and equity. And that particular group came together because of things that we were hearing from community members about their concerns that that things won't be addressed within communities of color, low-income communities, and other communities. So it was something that came from a question that that the people in communities had about being cared for. And as a result of that, a letter was written to the governor from the council asking that some type of group come together and look into some of the concerns that had been raised to the council by citizens of New Hampshire who represented either low-income communities or communities of color. So that was kind of the way that it all started. We were selected and we went on and did our work in the way that Kirsten already laid out, late nights. And sometimes I hadn't pulled an all-nighter in a long time, but I had an opportunity to do that. And what a better group of people to do it with than with the group of people that I did. I felt very honored to be a part of that. So the second part is, we receive input all sorts of ways. People could contact us through email. They could meet with us. We just extended ourselves in such a way because we wanted to make sure that the information we received was from people who were having the actual experiences or being able to express their concerns, and they didn't have another way to make sure those concerns were expressed. So things that you read in the report, those things are based on lived experiences of individuals. And those stories were honored as much as when we think about qualitative and quantitative data, stories are important pieces of data collection. And oftentimes with the traditional way of receiving data, those ways aren't honored, but we honored those because we know that those stories were valuable. And they needed to be expressed, and we needed to adequately represent them. So I just wanted to add that piece to that. A lot of my expertise are not in public health. I basically wanted to focus on pulling together some of the social determinants of health and really magnifying the impact that those social determinants can have on health outcomes and quality of life for individuals living in the state of New Hampshire. So I just wanted to put that out there. And so that's my little piece, and I'll pass it on to Bobby before we pass it back to Peter to put us into groups to have a brief discussion.